Hello and welcome to Scholarvision. I'm Dr. Richard Becker, the Chief of the Division of Cardiovascular Health and Disease, and also the Physician-in-Chief and Director of the Heart, Lung, and Vascular Institute at the University of Cincinnati College of Medicine. I'm joined today by Dr. Markus Gustche. He's an Assistant Professor of Medicine and the Director of the Interstitial Lung Disease Program at the University of Cincinnati Medical Center. Dr. Gustche, welcome to Scholarvision.
Thank you. Thank you for inviting me.
It's our pleasure. I have a few questions for you. And the first is, what is interstitial lung disease and what have we learned over the last decade about its presentation and its prevalence?
Yes, so interstitial lung disease is a term that is applied to a large heterogeneous group of diffuse parenchymal lung diseases. And these diseases can, the diffuse parenchymal lung diseases can originate from a large variety of different disease processes, connective tissue diseases, autoimmune diseases. They can be idiopathic, they can be related to an occupational, inhalational exposure, sarcoidosis. There's a very broad variety of different diseases. The unifying characteristic, though, is that they are diffuse, so they affect the entire parenchyma within the lung, and they oftentimes lead to pulmonary fibrosis, which seems to be the end point of the disease process. So when looking back and looking at how it has first started out describing these disease processes and identifying disease mechanisms, I think our appreciation for different pathways and different disease processes leading all towards that same endpoint has grown very much. And during that process, certain medications have come along, biomarkers, and of course we still have a lot of work to do, but I think that's how I would summarize interstitial lung diseases and possibly what the development in the field has been like over the past 10 years.
Yes. More common than we once thought?
I think so, yes. I think it's still a little bit under-recognized, whether it's the connective tissue disease-associated ILDs, where we know that quite a significant number of patients have subclinical disease that later on progresses to clinical disease, but also idiopathic pulmonary fibrosis, which often is misdiagnosed for a long time as a different disease entity, treated differently, and eventually these patients find their way to a pulmonologist who then identifies that this is actually pulmonary fibrosis.
Yes. So we have learned some things. There has been some progress. What do you see as being some of the most important advances in the diagnosis or treatment within the last 10 or even in 20 years?
Yes, so I think idiopathic pulmonary fibrosis, this is a very nice example, I think, where our understanding has really, the paradigm has really shifted from considering this as a inflammatory disease process that can be treated and mediated by immunosuppressive medication towards a more fibroproliferative disease process. And I think it became very clear this year with the publication of some trial data from various trials. One, the PANTHER trial that deployed prednisone and azathioprine, more directed at an inflammatory mechanism of this disease, and which had to be terminated because patients had an increased mortality and increased hospital admission rate. And then on the other hand, we had new drugs that came along like pirfenidone and nintedanib, that are more directed towards the fibroproliferative process. And in those trials, we've actually seen that patients do better in general. The disease progression is slowed down by these medications. And I think this has been a huge step into the right direction for IPF. Yes. And there are many other examples, too, where within connective tissue diseases, you may find that patients may be more responsive towards immunosuppressive medication, for instance, in scleroderma-associated fibrosis, Cytoxan, whereas in IPF, this would not be the correct approach. And so I think, particularly in this year, we've seen a lot of movement within idiopathic pulmonary fibrosis.
Sounds like it's been a very important year in terms of defining what the pathobiology is, which is always the key to understanding how you can best manage and treat.
Yes.
So even though there's been progress, what do you see as some of the greatest unmet needs?
Yes, so I think, you know, even within IPF, I think we still don't understand the disease very well. These drugs do not cure pulmonary fibrosis, so lung that has already exhibited fibrosis cannot be saved by these medications. I think we have to find ways to identify patients at an early stage. We also know that some patients respond slightly differently to the medications than others. So there's a lot of heterogeneity within this patient group, and particularly within IPF, the life expectancy can range between 6 to 9 months from diagnosis all the way to several years, up to 10 years in some cases. So that in itself, I think, tells us that this is a very heterogeneous disorder, and that there are probably different subphenotypes that we need to identify.
Yes.
And I think one of the challenges will be to design biomarkers that can discern between these different patients. Those could be blood or tissue biomarkers, fibroblast phenotyping. There are many different approaches that are currently being developed, and that can then also allow us to further personalize our approach towards the management of the patient, because some patients may respond to one drug that inhibits a very particular specific pathway, whereas others may not, and they may have other pathways that they may be more responsive to if they are being inhibited, as opposed to another group of patients, even though they all present with the same phenotype clinically.
Yes. So it sounds like a more patient-specific approach is needed.
Yes, I think so.
Yes.
Yeah.
Tell us about the Interstitial Lung Disease Program here at the University of Cincinnati.
Yes, so the Interstitial Lung Disease Program here is comprised of 4 physicians. We have practices at the Medical Arts Building, and we see patients with a large variety of interstitial lung diseases. We have a multidisciplinary team that comprises chest radiologists, a lung pathologist, and we collaborate very closely with our colleagues from rheumatology for the connective tissue disease-associated ILDs, our colleagues from pulmonary hypertension team, because a lot of patients have pulmonary hypertension and interstitial lung disease, and many other specialists as well. So it's really a nice multidisciplinary approach, which I think is needed because this is really a disease process that involves many different organs.
Yes.
And what we'll see probably in the future is that just like COPD being a systemic disorder, be considered as a systemic disorder, we're probably going to see that as well with IPF or ILD, some of the interstitial lung diseases.
Yes.
And we already know that from the connective tissue disease-associated ILDs, that's a classical example where this is a multi-system disorder, with the lung just being one of the manifestations.
Yes. Sounds like that's particularly important and something that fits very well into the construct of an institute or a university-based medical center, because you need all of that expertise to get it right.
Yes, yes, absolutely. And I think my goal would be that we really create a patient-centered medical home where patients with complex, advanced interstitial lung disease can turn to in order to get the best possible care. And at the same time, we're able to further define what exactly the phenotypes are that we're looking at, how we can develop biomarkers. And one of the areas I think where it's been very nicely demonstrated is in LAM, where a disease process with lymphangiomyomatosis, disease process that's very well characterized phenotypically, that has led to the discovery of a biomarker, a blood biomarker, VEGF-D, and led to the discovery of sirolimus as an mTOR complex inhibitor that can halt the disease progression. And I think that's really a model. It's a rare disease, of course, but I think it can be extrapolated to other interstitial lung diseases that are perhaps more common, like IPF or some of the connective tissue disease-associated ILDs or other idiopathic ILDs.
Yes. Sounds like a very exciting time, and that you and your colleagues are poised to make some discoveries and honestly to make a difference in terms of the patients that we care for.
Yes.
Good. Well, congratulations to you and your colleagues on your great work. We'll look forward to hearing more about it in the months and years to come.
Thank you.
And thank you for joining us on Scholarvision. Until our next program, keep asking questions. Inquiry is the true compass of scientific and medical advances.